As Dr. Meyer said, we're welcoming back Dr. Judy Fader to continue the discussion on problems in the U.S. healthcare system and why it's so hard to fix. Dr. Fader is a professor in the McCourt School of Public Policy and served as the dean from 1999 to 2008. She is a leader in the health policy, focusing her work on the nation's health insurance system. So without further ado, I'll let her take it away.
Thank you, Bronwyn. Pleasure to see you all again. I hope you've been able to contain or retain your enthusiasm for a week. And we're going to pick up where we left off. I will restate what I see as the big political challenge of getting everybody affordable, quality healthcare coverage that makes them able to get healthcare when they need it. It's the way I think about it is the 85-15 problem. If we, through Medicare and Medicaid and tax-supported employer-sponsored health insurance, cover the bulk of the population, it's very difficult. Well, excuse me, let me start with very easy. It's very easy for the opponents of an expanded public role in health insurance coverage to scare those of us who have coverage into believing we will be worse, not better off, if the government becomes involved and extends coverage to everybody. And so the challenge, and I described to you briefly how the Affordable Care Act addressed the challenge. The challenge is to design an intervention, a law, and then a program that can cover the people who don't have health insurance without disrupting or minimizing the disruption of the people who are already covered. So you're with me on the dilemma? All right. And so you remember, I think I did tell you, and I would just like to spend a few more minutes on how the Affordable Care Act worked. You remember that I told you that it was very exquisitely designed to be narrowly focused in order to minimize disruption. And so it addressed two fundamental coverage problems in our employer-sponsored system. And the two problems were that Medicaid excluded the adults not connected to children and without disabilities, excluded them from Medicaid coverage. They were not eligible for Medicaid coverage, and that was one problem. And because they also were not getting coverage through their jobs, we needed to address the second problem, which is that the market, what we call the non-group market, because it's individual, it's a person goes and buys for themselves or their family on their own, not through their employer, their own policy. The non-group market was discriminating based on health status because they didn't want to be stuck only with sick people and because they wanted to maximize their profits. So those are the two problems, very modest effort on cost containment. The coverage problems were focused on those. So let's just spend a little time talking about how the Affordable Care Act works. And now we should think about it, I don't have to call it either Affordable Care Act or Obamacare. It is how do marketplaces work. The administrator of the Center for Medicare and Medicaid Services, who I'm proud to say, Chiquita Brooks-LaShore, is an alum of our program and a former student of mine of the McCourt program. Chiquita says that she's responsible for the 3 M's. She's responsible for Medicare, for Medicaid, and for the marketplaces. So we ought to think about it as the marketplaces. It's more than marketplaces, but you start with the marketplaces as the place where, as an organized, rule-directed location, that individuals who do not get coverage through their employers, because you're not allowed to go to the marketplace if you get good enough coverage through your employers, and there are rules for assessing that good enough. So it's a place you go for coverage. and you are given the rules, all in the insurers who participate in the marketplace, which are run either by the federal government or in combination between the federal government and the state, or the state. The marketplace, the insurers who come to that, who offer coverage in that marketplace, have to play by rules. They have to provide a certain adequacy of coverage, which is not precisely defined, but it was established as comparable to other kinds of coverage in the state, like for state employees or standard managed care plans. So it is regarded as fairly broad coverage. They have to take everybody regardless of health status. They set their own premiums, but they take everybody regardless of health status. The law was designed so that everybody had to buy insurance. We're going to turn to the politics. That has not stuck. The mandate has not stuck, but people do get subsidies to buy in the marketplace. And that subsidy varies with your income, and you get more if you're very poor, down to the poverty level, because below that level, you were supposed to get coverage in the Medicaid part of the law. And you have to, above poverty until recent law, I'll do with the updates, but as the law initially passed, even people with incomes at the federal poverty level, remember that would be, at federal poverty is about $13,000, $14,000 for an individual. Even they had to pay something. And then people had to pay more as a percent of their income. That's what's capped. Up to, in the original law, 4 times the poverty level, so about $50,000 or $60,000. And they shop with their vouchers and can choose from among plans. The plans are expected to be competing for those vouchers, the subsidies, the tax credits that people get, in order to profit, which is what we're writing on here, follow the rules and maximize their profits in this regulated system. That's the way the marketplaces work. I think the Medicaid expansion, which we talked about, was just supposed to make state Medicaid programs, federal state Medicaid programs, were supposed to be available to everybody with incomes below 138% of poverty, although, as you know, and we'll talk about a little more, not every state complied. So do you kind of get the marketplace? Questions about the marketplace? I didn't talk to you about the metal tiers. So the way your subsidy from the government is determined, it's based on the silver. The tiers are bronze. The princess that I am, I think about this in terms of jewelry: bronze, silver, gold, and platinum. And it's supposed to be based on the comprehensiveness of its coverage, on how much you'd have to pay out of pocket in the plans. And your subsidy is set at the level. What the plans get paid is tied to the bid. They all bid for what it's going to cost, what they're going to charge, what the premiums are going to be. And the subsidy is set at the level of the second lowest cost silver plan. And then people know how much their dollars are, and they shop and they rely on the internet, to the website, to help them choose plans. And the law provided for substantial consumer assistance to help them understand what's going on in those plans. So, okay, so I think I've told you everything I think I need you to know about those plans. So I'll ask you once again, any questions?
It looks like BJ asked in the chat about healthcare for small businesses and the health market being expensive.
So a good question. There was supposed to be also a separate program for small businesses. My understanding is that never really got off the ground. But the people in small businesses are able to shop in the marketplaces, when previously they had no place to go. Brian, I see your hand up. Let Bronwyn.
Hi. In my small business, a few years ago, when I went on the marketplace, the plans through the small business were each $1 cheaper than if individuals got them. So I just said, I won't go through the hassle of managing this plan. You guys can get your own for an extra $1.
Yeah, it really wasn't very different from the letting individuals shop is my belief about that. But those individuals are able to be, those people, employees of small businesses are, as you said, Brian, able to get coverage through the marketplace. Bronwyn, do you see another question?
Yeah, Maria just asked, how are insurers in the marketplace paid by the federal government? Is it capitation?
It works. Think about the what government does is subsidize the individual shoppers, as I was talking about, by giving them what's called a refundable tax credit, which means and you get an advanced refundable tax credit. You get when it's an annual enrollment time, and the reason there's a single time to do it annually is, again, so that people don't wait till they get sick to sign up. We talk about that. When you have in the open enrollment period, you go and you carry with you that tax credit. And that tax credit is paid directly to the insurer. You can think about it we usually call it capitation when we pay a provider a lump sum payment for delivering care to an individual. You're paying a lump sum or a monthly sum to an insurer, but that's just like we call that a premium in the insurance industry. You're just paying your premiums. Did that answer the question?
Maria, was that okay?
Maria, did I get you? I'm not seeing you. Maria, wave your arms.
Thank you for the explanation.
Okay, and that worked for you?
Yes.
Yeah, and they pay the amount that government, they pay the subsidy amount. So if more has to come from you if you are at a higher income.
And then Sophia has a question.
Not really a question, but to kind of add to that, when I used to enroll people, explaining to them, just to add to that, I would always say, I think of the government, you provide the subsidy, they're kind of third party. So you can pay through the marketplace once you enroll in a plan, but I would always tell people, you're better off calling the health insurance company, call them. You can pay over the phone, but pay them directly because they're the one insuring you.
To make sure they actually connected to their plan. Is that what you were concerned about?
Yeah, to make sure that because every once in a while, sometimes things would fall through the crack. So I'd always tell people, just reach out to the insurance provider. They'll get your information in a few days.
Good. And I want to talk to, and I'm sure has something to offer in a minute. I want to talk to. Thinking about how well this worked, to talk about the challenges of enrollment, because it is not as simple as we might like it to be, and I think that firsthand. Okay, any other good enough?
So it looks like we have a couple of questions in the chat, actually. BJ said Medicaid recipients often have trouble getting appointments. They are low on the priority for medical care still. How can that be changed?
Okay, hold that thought. We're going to come to it in a minute.
Okay, and then Lydia asked, in European countries which provide their citizens with healthcare, is the term marketplace used, or is this concept confined to the US?
I believe the Dutch system has some shopping involved. Others may have some shopping involved, but it is a much more extensively government managed process. I laugh at the name marketplace because when I was in the Clinton administration and we were doing what I think of, and I've already described to some of you, as Obamacare, Hillary Care was Obamacare on steroids. We first were calling these entities co-ops when we never enacted this law. This was just us trying to sell it politically. We called them co-ops. That they polled, and that was they did a poll, and they found that people thought that was too socialist. So then we called them alliances. Then I had a friend who said to me, just tell me, what is an alliance? Does an alliance have a waiting room? So that was confusing to people. Nobody knew what the hell that was. Then we come to the Affordable Care Act, and in the law, they're called exchanges. Now that apparently didn't communicate well either. And now they're marketplaces. The way to think about them is that they are an organized place to shop for healthcare. And I'm going to talk about shopping in a minute, as to what it's meant to achieve and what we know about whether it does that or not. Okay? All right, so now, if it's all right with you guys, I want to let me know, Bronwyn, if somebody's got another question. I want us together to assess how well this law worked. So what is your sense of what impact it had? Let's start with coverage. Did it make any difference? Come on, you must have some feeling.
I think so.
Okay, yeah, atta girl. That's Ella.
You had a bunch of people who wouldn't leave their jobs because they couldn't get insured. Like what is it? 20 million people were insured after the ACA.
20 million people. That is a pretty big number. That is not nothing. 20 million people got health insurance under this law. I had multiple reactions to that. One reaction was, I knew they needed health insurance. I didn't know they knew they needed health insurance. So that is pretty amazing. Number one, how much it mattered to people. And 20 million is a lot of people. Yes, you'll give me the 20 million. Granted, we have close to 50 million uninsured, so we're still left with 30, but 20 million is a lot of people. And you told me last week how health insurance matters. So every one of those 20 million people is better protected. We'll talk about how well protected, but better protected today than they were before. I was going to give you another piece of a reaction to that. If we had that impact, despite the fact, and most of you probably were paying no attention at the time to what was going on with the implementation of the Affordable Care Act, but the coverage went into effect in 2014. It was a freaking disaster. It was, the federal government completely blew it. The computer system did not work. They had 3 years to get this ready, and they couldn't make it work. It, in my view, should have been much more than a computer system, but even the computer system, the internet mechanism for enrolling people was appalling. And since I am a believer in government management of services, I have to tell you, it gave me serious pause. So we didn't make it easy for them, and still 20 million people showed up. Bronwyn, I think I see a hand.
Go ahead, Sophia.
I was just going to say, even though, this is 20 million people, even though we still have so many people uninsured, every person, being able to get coverage, it makes a difference. I enrolled people who never had health insurance in their entire life. And when I tell you, it completely changed their life after that, they were able to get access to care. Every single person counts, and it's so very important.
Oh, Sophia, that's lovely to hear. Can you give us an example of when you say it changed their lives?
Yeah, so I had a client, and they had maybe been to the doctor once, and they were about 50 years old. And so as soon as we got them enrolled in coverage, they were able to go and get their annual women's wellness visit, their annual physical, and they were able to, get checked out, get the medication that they needed to treat the condition that they ended up finding out that they had. So I think that
Thank you. No, we always, it is easy when you do what I do I focus on the money and the incentives and the data, but you have to always remember, no matter what field you go into in policy, you have to always remember the people that you're aiming to serve, and the impact, I think, has been extraordinary. All right. So, and the other thing I'm going to say is we did not have an explosion of healthcare costs, which was what was argued that we would have. That did not happen. So that was all quite good. Now, okay, enough singing its praises. What's wrong with it? We've got some Medicaid issues that somebody wants to discuss, but let's talk about the marketplaces first. What do we think about how well the marketplaces have functioned? Anybody? I mean, I know Sophia's got some experience. Anybody else have experience or information or a point of view or something you heard? Yeah,
go ahead, Brian, and then Ella.
I don't know if this is a function of how the marketplace, or this is about how the marketplaces function, but the issue of really high deductibles is a problem.
Got it. That is, I think, let's start there. So the question is whether is the adequacy, two issues I would focus on in response to your question. One is whether the vouchers were adequate, the subsidies that people get, and two is whether the coverage is adequate. And so let me get the other questions and see before I go on to that. Ella, did you want to go next?
BJ can go. I was just going to talk about subsidies and their adequacy and people affording plans.
Okay, good.
Well, the one part that my research has, I need to prepare people. This is very triggering. And so just so that, if somebody wants me to stop, I will. The one part in the research that I've come across that I'm working on my PhD is that children were abused in the system, and particularly in foster care. There are states right now that had to place algorithms, data to pick up on the toddlers that were 3 and less. We're including babies that were put on 6 or more psychiatric drugs. They were injected with them. And it was a
BJ, if I appreciate it, and I'm only interrupting you because I want to, not because it's horrifying, it is horrifying, but I want you to, were people taking advantage of their vouchers in order to make money, or what was going on?
Well, doctors were making money. They were making a lot of money. And so, but the good news is, because of these algorithms and states finding that this was happening, it was an abuse that was going on. Now, other doctors have seen that this has occurred, and now those rates are starting to go down. But it was an abuse on the system to get money for both labeling and then prescribing all these medications that were given to them. That's one of the abuses I've seen.
I appreciate that, and I did not know about that. And if you sent me something, I'd appreciate it to read about it. It's horrifying, and it sounds as though any system that is facilitating a payment for something can be abused, and that is a great sadness. But I think when you look at a policy and its goods and its bads, you need to be sensitive to the ways in which it can be manipulated. So thank you for that. Was there something else that somebody wanted to raise?
There was another comment in the chat about subsidies. I don't know if Ella wanted to talk about that first, or
should I just go to what I tell you about the subsidy? Okay,
sure.
Okay. So the two, we're going to focus on the adequacy of the vouchers. I told you that what they did is limited the share of income you had to pay towards your premium, and you had to pay something ranging from $2,000 to I think initially it was 8% of your income, and initially that got cut off. If you were at 4 times the poverty level, you're on your own. So it scaled down as what you had to pay actually went up. The subsidy went down as your income was higher. Does that make sense to everybody? Those subsidies were not very generous, especially at the low end. And where they cut off, since the law ultimately allowed some variation in what insurers could charge based on age, not as broad, not health status, but age, which you do need more health care on average as you get older. It's not as great a variation. It was about 5 or 6 times from young to old. Before the Affordable Care Act, it was limited at, I think, 3 times. If you were older and had an income above $60,000, you didn't get any subsidy. And so for that group particularly, there was not enough help. For others, whatever percent of income they had to pay between 2 and 8, it was not insignificant. 2% if you're living at the poverty level, 2% of your income is not nothing. Since you can barely get by on what you got. So the subsidies were regarded as, were experienced as inadequate, particularly when one looked at what happened to the coverage in the plans. And now I'm going to talk a little bit broadly about shopping. So the plan, the concept of marketplaces and why they are regarded by some as an effective means to provide people health insurance is that you get the argument is that the insurers will compete for enrollees for the money they're going to get in premiums. They all want to make money, and you're counting on that. They will compete for them by offering care efficiently, quality care, responding to consumers so that everybody's happy and everybody wants to enroll. Not so much. Their primary means of competition is to keep their premiums down. They keep their premiums down, or one of the mechanisms by which they can meet. They keep their premiums down by making their deductibles high. What that means, and you have to look at both, as I'm sure Sophia knew when she was advising people. Everybody's looking for a low premium, but one way to keep premium low is to have your benefits not kick in until you've paid a substantial amount of money out of pocket. Everybody following? Right? And even though one of the things the Affordable Care Act did was to cap out-of-pocket spending, it did so at a high level, which for some modest income people is not protecting them. My friend Karen Politz, who's an expert in this area, says, what difference does it make if it's $6,000 or $60,000 if you don't have it? If you don't have it, you go bankrupt. And we know that people, a large portion of the population, the population that didn't get employer-sponsored coverage, are low and modest income people. So it meant that the coverage they were looking at had high deductibles. So the competition was not about efficient delivery of care. It was about how cheap can I make this care and get you to buy it. So people who looked at it understandably said, I'm going to have to pay a portion of my income. That means I'm sacrificing food or school supports or my vacation or something meaningful to me to get coverage that's going to bankrupt that I'm not ever going to be able to afford to use. So that was I hope that addresses the question. That was one significant flaw in the initial program, and I'm going to get to how we have somewhat addressed that in a little bit in a minute. Another area. So did I get at the questions you were asking? Does somebody want to comment on those things?
Yeah, Gail, was that okay? Or Ella, did you have anything to add? No. Okay, I think you're good.
So the other way, and another problem with the law, and also challenging this shopping idea of a way to get people, the language is often used to say, to let people, enable people to get the coverage that works best for them. And I'm saying it with a little bit of a attitude in my voice, because I don't know how you're supposed to know what coverage is supposed to work best for you. It is true that if you're richer, you can pay less in premium if you can afford the deductible. That I kind of get. But if you choose those kinds of plans, remember that risk pool, you're leaving those other people who need comprehensive coverage more on their own. They're going to have to pay more. Okay. So it's a problem. If you choice, I may have said this last week, an early lesson I learned is choice and risk pooling insurance coverage, where we spread the cost, don't go too well together. You also have no clue what disease you're going to get if you're healthy, or why you're going to need healthcare. So it's a little hard to know how to choose. And the other piece of this was supposed to be, the idea is that they'll compete by delivering care efficiently. Not so much. They compete by, oh, there's a cute kitty. They compete in part with narrow networks. The plans limit the providers you're able to see. The availability of providers in these networks is less than what is provided in employer-sponsored plans. And although in theory, they're connecting you, or they're relying on efficient, high quality providers, the evidence is not real supportive of that. The last comment I'd make on this is that there are studies of how much people shop for care. Shop for insurance or shop for care, because the other argument is having people pay deductibles makes them interested in choosing the best provider at the lowest cost. The evidence tells us people don't shop for care. Even when they're given information on how to shop, on prices, they do not use it. They do not understand or want to shop for health insurance. So this market concept is pretty powerful in terms of one school of thought, Republican school of thought, on how to transform the Medicare program, how to change employer-sponsored insurance, how to run the whole system to have all of us shopping. The evidence tells us that that will disadvantage people when they need care, and is not likely to lead to efficiency, even if it does lead to lower costs. Sophia.
I think, Sophia has something to add.
I just had a quick question. So the out-of-pocket limit continues to increase every year. I can't remember, is there something in place that there will be a cutoff for that? I mean, as it continues to just climb up and up and up every single year.
It rises. I'd have to look, and you can look. The Kaiser Family Foundation has very good documentation. You may just be able to Google this particular question. What are the increases in the out-of-pocket limit? My recollection is that they're tied to, I can't remember if they're tied to inflation or health cost inflation. Now, even inflation would be pretty bad in the last year. Health cost inflation is usually worse. So you are right to be concerned about that as an issue. Brian?
You were talking about people not price shopping. Do you want to discuss how effective or ineffective the requirement for hospitals to make their prices public has been?
Yeah, I think I already answered your question. Has been, I've not seen evidence. I am very skeptical about its impact. And
do you think that's because the hospitals are deliberately making it so complicated that nobody can understand it?
I don't know what I think. I don't think the hospitals love this, but I think even if they make it simple, I do not believe that's the way people get healthcare. They go where their doctor is practicing and assume that's the right place for them to be. Okay. There are some other problems. I like surprise billing. You didn't know your doctor wasn't in your network. We're trying to address those. There are some provisions. So the problem is that when the way to think about what you're going for in a plan like in health, what we typically call health reform, in getting everybody meaningful insurance, you want it to be accessible to everybody without, so a lot of A's. Accessible to everybody without regard to health status. You want it to be adequate, which means you want it to cover folks so that they really can afford care. You want it to be, affordable, adequate, accessible, affordable, adequate, and you want it to be administratively simple. You want to think of those four things. Got serious problems here in the marketplace, in some of those issues, some of which I'll come to in a second, that we have addressed. But before I do, I think we've got, I've also left out the Medicaid piece. Another big, in fact, it often comes first, is the coverage gap. Does somebody know what I'm talking about? That's the jargon for the coverage gap. For the Medicaid, okay, that is jargon. Sophia knows, but I'll go with it. Okay, the law was written. So, I see a hand.
Oh, yeah. Oh, Evo, if you want to go ahead.
It's me. I think I keep getting off. Don't worry about it.
Okay, so I should just go with my explanation?
Yes.
The law was written so that the intention was that everybody with an income below 138% of the poverty level would be covered by Medicaid, changing the federal Medicaid law so that instead of leaving out those adults who were not connected to children and not disabled, everybody below 138% of poverty, no more deserving and undeserving poor, everybody at that income would get Medicaid, and the feds would pay the difference. Feds would pay for that expansion. And above that level, you'd shop in the marketplaces with an income-related advanceable tax credit, refundable. So you got it no matter whether you pay taxes or not. That was how the law was designed. And now we're shifting into the politics, because one venue for the politics on the Affordable Care Act was the courts. And this was small business that took everyone. Is this the one I want? It is that case, NFIB. Yes, that challenged the law. It went to the Supreme Court. It challenged the mandate that everybody had to buy insurance. And the Supreme Court did not find in favor of the mandate, but it said that the mandate was functioning as a tax because there was a tax penalty if you didn't participate. And so they left the mandate stand. It challenged the Medicaid expansion, even though fully federally funded, as coercion of the states. I can't say it with a straight face. Because the feds were paying 100% of this. It was declining, in fairness, to 90% over time. But every study showed, and we have experience with this with Medicaid, that it is financially beneficial to the state to be spending on healthcare. It enhances the economic growth in this, the economic, essentially the GDP of the state. Resources. So that generates tax revenues, and it is to the benefit of the population. But the court decided that was not the case. I could spend more time on that. I was tempted to say that, but sarcastically, the court in its wisdom, it was clear the court, there is an article on the political deal that was made to let the mandate stand and let the and undo Medicaid as a deal, political deal between Republican-oriented and democratically-oriented justices. And so what I would urge you in general is to think of the court as a venue where political battles play out. It used to be, when I taught it that way, it had, even for myself, I had to think hard about whether that was true, but I don't think any of us have to think very hard about that being true these days. So I think so the courts made the Medicaid coverage voluntary. When you look at the people left out, this is the neediest population. It's the population whose income is too high for Medicaid in those states that set Medicaid eligibility at very low levels, and too low because the law only let the vouchers, the advanced tax credits, they only let them go down to poverty. All right, so that's a hole. Just for your information, the coverage gap, let me see if I have it. The coverage gap it is a few million people, but it is a small portion of the uncovered after the Affordable Care Act. About half the population that isn't covered is ineligible. They're ineligible. It may have changed some with some recent legislation, but the half are eligible but not participating for the subsidies aren't good enough. They have an employer offer, which makes them unable to use the marketplaces. They're undocumented, or they're in the coverage gap. So that's kind of, and the coverage gap by there, I confuse them. So the ones who the subsidy is not good enough for are the covered but not participating, and the other, and that would be true, they're not participating in Medicaid either, but although they could, but in Medicaid you can go when you're sick. The parts who are not eligible are the people who have the employer offer, the undocumented, the people in the coverage gap. So I know I made that totally confusing, and I can send you something that will make it clearer to you, but unless somebody wants me to go through it again while I look at my paper, but it's okay. We're good enough. All right. So let's go now to the politics and the courts. The courts were one of the places that the opponents of the Affordable Care Act fought it. And I have to talk faster. So I'm not going to have as much time because I want to get us to what we think, where we ought to go next. So they fought this. They fought them on the land. They fought it on the beaches. Essentially, the Republicans fought this every way they could. They tried to repeal it a gazillion times. None of their repeal measures, it was first just going to be repeal. Then it became repeal and replace because, oh my God, every time they put out a proposal, the Congressional Budget Office would tell you that millions of people would lose insurance. And even they had some pause. Their states had, their governors had pause. So the hospitals in the states didn't want to give it up. The insurers in those states didn't want to give it up. So, and nevertheless, so they claimed there was going to be a replacement, but their replacements were lousy because the Republicans generally advocate solutions that let you choose the coverage you want, which means that the sick and the healthy aren't together, and that people have to pay too much when they're sick. So my shorthand on why it is that they could never pass a substitute is that it is because the Affordable Care Act was a Republican plan. Giving people vouchers to go shop for health insurance and assuming that all's going to be well, there are some good rules in these marketplaces and they're going to compete for you and it's going to be all sweetness and light. That is a Republican plan. It was, in fact, it was developed years ago by a fellow at the Heritage Foundation. It was proposed. It was enacted in Massachusetts. It was the Romney plan, a stronger version than even the Affordable Care Act is. But shopping for stuff in a marketplace with a voucher, that's it. So you can't get much gentler than what we did in the Affordable Care Act, and Republicans couldn't possibly come up with anything better. And we almost lost it. It stuck by 3 votes. And that, when I tell you all these people didn't want it taken away, that is, it didn't just spring up full blown that they were advocates opposing it. There was a very aggressive advocacy effort in many states and nationally to demonstrate the cost repealing the Affordable Care Act and the political cost. Ultimately, the Republicans, they bore some of, but essentially those 3 votes meant that the law stuck. Okay, now we've improved some of the holes that we talked about in the law. And you asked about Medicaid, whether Medicaid is good enough. I'm sorry I couldn't pass that question. And because I talked about the coverage cap, Medicaid does pay providers less well than Medicare or private insurers, but the studies continually show that people on Medicaid look much like more like insured people when they need care than uninsured people. In other words, they get access to care. It may not be the same providers as people who are with private insurers who are paying more. So there are definitely issues of problems with Medicaid that I'd be happy to pursue with whoever raised them. But I think that was an answer to your question. So let me talk about now where we are and then ask you to talk about where we ought to go. So I forgot what the ARA stood for, but the law that was passed during COVID to enhance people's protection in the Affordable Care Act to me, most importantly, to improve those subsidies, but some other measures as well. That has now been it's been kept in the Inflation Reduction Act, but they couldn't make it permanent. They didn't have the political clout. Thank you, American Rescue Plan. Thank you. I appreciate that. It's tough to keep track of these acronyms. So so ARPA extended it during COVID, and then the Inflation Reduction Act, the IRA, has extended it to 2025. All right, so it's improved, but not permanently improved, and that's important. What's not in that legislation, we couldn't figure out or have the political wherewithal to close the coverage gap. That's a big problem, right? Those are the poorest people in states that will not, for political reasons, expand coverage. So we fixed some problems, not all. The other thing that has happened, you raised the issue of deductibles, alongside the big improvement, the 20 million people who got coverage. We've had a big increase in people who are labeled underinsured. That is, they are at risk of spending more than I think the standard is 5% of their income if they face a serious illness. Deductibles exist, high deductibles exist not only in the marketplaces, but also in employer-sponsored insurance, because that is the easiest way for an employer to reduce what their employer spends on healthcare if they essentially increase what we pay out of pocket. So significant problems, and you'll remember I told you we largely left the employer-sponsored insurance system alone. So plenty to fix, plenty of 30 million people uninsured, even though we've made the marketplaces work better. Well, let me just say, made the marketplaces work better, and Medicaid's operating in most states, the Medicaid expansion. But plenty to fix. Now comes the question of how to fix it. And I'm going to give you, I told you that last week I spent a lot of time giving you my sense of how we got stuck with this half-assed system that systematically excludes people and doesn't control the costs with what we're spending on healthcare. We got stuck because we built a system that was not government-based, that brought everybody in through their employers with tax subsidies, has built Medicare and Medicaid around, and now the ACA, the marketplaces around that. But still, we leave people out and we don't control costs. So one solution to that is single payer, that we have a government health insurance program. But I've told you that it's pretty damn hard for us to get. That path dependence keeps everybody stuck where we are, and so is a political challenge. So this one path is to keep on patching. So you'll note in COVID, during COVID, it's conceivable, but President Biden ran on a public option. Could have, if we had a government that really was able to function at the high levels, could have done single payer when the employer-sponsored system fell apart because people weren't working. But no, we didn't do that. We shored up we paid their cost of the employer premium. We kept them in their private premium, private insurance, and we shored up the marketplace coverage, as I've just described to you. That is the alternative strategy, that you just keep on keeping on, perhaps with a more aggressive effort to contain healthcare costs. We did see some action on drug prices, public control of drug prices, albeit limited to Medicare. I'm giving this issue, this challenge, short shrift, but I'm turning it back to you, and I want to hear I want you to raise your hands. How many of you think we ought to go to single payer? Okay, so Adrian and I have talked about armies. You and what army? I just want you to be an army for that, but to recognize your challenge. How many of you think that, given the challenge, and you're allowed to vote both times, that we ought to keep doing our damnedest to make all these programs stronger? I mean, I just want to tell you, if you watch the State of the Union, you saw that President Biden loved this, called out the Republicans because they want to limit Medicare and Medicaid. And despite the way they reacted to that charge, they do. They would like to have everybody shopping for healthcare with, I would argue, insufficient regulation and insufficient vouchers. So faced with that, how many of you think the best course of political action is to keep on patching? All right, so speak up and tell me. I think you got to do both, yeah? Somebody respond to me. Tell me your strategy for getting us a better system. Or getting us never mind better system. And we've only scratched the surface of the challenges. We haven't talked about rising prices as private equity is participating in the healthcare industry. We haven't talked about the horrendous differentials, disparities by race in our healthcare system, the relatively poor quality of our healthcare system relative to that in other countries. Lots to work on that I hope you all will do. But somebody comment. Susan, you just put something on the chat.
I did, but I'm not a student in the program, so I want to defer to them if they want to make a comment.
Thank you, Susan.
I can go ahead, Susan.
Okay, well, I think to me the issue is, we spend so much money on healthcare, and yet it's such a convoluted, expensive system that we're not really getting what we're paying for. So I think if Republicans, and I mean, my belief is that essentially our tax money is being, funneled to these private insurance companies. And I mean, I don't know how the legislators get kickbacks or paid for this situation. But I mean, if Republicans really believe in small government and not spending a lot of money, we need to go to a single player system and stop, basically paying like exorbitant rates to private insurance companies who oftentimes don't cover us.
Okay, so thank you, Susan. I appreciate your thoughts, and then it looks like Brian's up. But let me respond to Susan. I want to modify in order to clarify where the money's going. Yes, insurance companies make significant profits, but what drives the costs of healthcare is what we pay providers, Susan. So essentially what we would need to do, and what single payer would do, but you also could do it without single payer, is regulate the prices that we pay to providers. This comes as a shock. I had a provider and a doc in a class last semester who said all the money is going to insurance companies. That is not correct. The difference between us and what other countries pay is the prices we pay providers. So I hear what you're saying. I would just push back on you a little bit. Say Republicans want low taxes and small government. And in order to make the system fully private, government spending would go way up because we would pick up everything that is now off the books because the employer is paying the premium. And we would need not only government regulation, but way more effective government regulation than we've got going in most of what we look at. So it is, and providers would raise holy hell. Brian.
I have a couple of comments. To address earlier, you asked us to raise our hands, and we all raised our hands to two things that are somewhat contradictory.
Well, one, you got to kind of do your best, but you're right.
Yeah,
the more you dig in, yep.
We need to have our ideals, but we also can be pragmatic. And I think that's where we should be in this situation. I think we can take some inspiration from a couple of political movements of the last half century. One I'm in favor of, one I'm not. One is the fight for marriage equality, and the other is the fight to overturn Roe v. Wade. These are two groups, very different groups, who had people who were making very serious, very long-term plans, and they were starting piecemeal and changing the attitudes of the public and changing the makeup of the government, the legislatures, and the judiciary. And what I think the people who are in favor of universal healthcare or single payer in this country aren't doing is thinking about what's that long-term plan? What can we do now, not to get Medicare for all next year, but to have a plan, to have a plan ready so that when the people are ready for it, it's ready to go, just like gay marriage was.
I think you make a very good point. The difference being that you have to implement. You don't have to do much for gay marriage. You got to implement the single payer plan. And I would say that I applaud or endorse, share your view about a long-term political movement and things to think about that that we can do is that we need better government oversight of the programs that we have so that they are managed well, that we need better payment oversight so we are getting better value for the dollar. And we're making some headway on that, but not in the direction.
Part of the plan is demonstrating that the parts that government are running are actually running well.
You got it.
And we're not doing a great job of that. And I think, to build on what Susan said, there are many, many great conservative arguments for universal health care. There are different ways to go about getting it, but I think part of what we need to be doing is changing the hearts and minds of conservatives to realize that the system we have isn't actually within their value system.
That's quite interesting, because you'll have to teach me what that it is, because I think it's working fine for them.
I think, like, the simplest example is that wealthy people say they don't want to pay for the healthcare of the poor, but they're paying for the healthcare of the poor. When a person of low income goes into an emergency room and gets the most expensive, least efficient possible care for themselves, the system is paying for that one way or the other, and ultimately the wealthy are paying into that system. Real fiscal conservatives should want their money to be spent in the smartest, most efficient, least wasteful way possible. And now their money is just being wasted. They should be irate about that.
I appreciate. I think that's a good argument, and go get them. Adrienne.
So I agree very much with what Brian said, and just wanted to bring in not only the high cost of drugs and other therapies. So I think that the pharmaceutical industry really has to be brought into this conversation in terms of how much that we spend on drugs and therapies. But I also, one of the reasons that I support a single payer plan is that I don't think anyone in the US gets good medical care, including the well-insured. So if you're well-insured, you're being overtreated. You're getting surgeries you don't need. You're getting medications you don't need. You're getting care that you don't need that may ultimately be bad for you. So it's not just the underinsured who are getting poor care. Our profit-driven system means nobody gets good care.
All valid points. And I would say that while I'm preoccupied with prices, which I believe are fundamentally driving the system, there are efforts afoot that are to enhance the responsibility for unnecessary care. I'm not convinced that at their effectiveness, but I think that is the thrust of cost containment efforts and quality improvement efforts at the moment. Not because I disagree with you, but because I wouldn't want people, just like I don't want you to think that insurance companies' profits are the reasons that our costs are so high. Although the pharmaceutical industry is particularly egregious and particularly visible in ripping us off, they are a small portion of our healthcare costs. And so when you think about wanting to contain our healthcare spending, which I am all for, you are also looking, or you're looking primarily at hospitals, at nonprofit hospitals, which does not make them good guys, and at physicians and other healthcare providers. I just want you to know what you're up against, Brian. So,
I am well aware.
Good.
Of how big this fight is.
Good. So I always, I mean, I think we are ending on an up note. I think we are at closure time. Are we, Bronwyn? Is that right? I just want to be absolutely clear that I am with you in this fight. I can help. I'm happy to help any of you who are interested in the field, whether you want to fight or not, but even better if you want to improve the system. And my goal is just to arm you, and so that with the experience that we've had over a century, the experience, not the experience that I have had over 50 years, which is shocking, but true, so that you are going about it in a thoughtful fashion. And it seems that is absolutely what you're doing. And I'm delighted to see you at it. So keep it up.
Are there any final, oh, go ahead. Are there any final questions from the non-happy students?
So if not, it's probably time to take a break and invite the happy students to come back at 1:10, let's say, to continue. Is that long enough, Dr. Fader? 5 minutes?